Hello, my name is Salvatore Serra. I'm a fourth year medical student at Wayne State University, and today I'll be presenting a case of sepsis pneumonia in a patient who I encountered at Henry Ford Hospital in July of 2025. I hope you enjoy. The patient is a 57-year-old Caucasian male who presented to Henry Ford's emergency department with new headache, malaise, chest pain, and shortness of breath, which first began 5 days prior to presentation. Of note, the patient and his wife reside in Southern California, and they were traveling first to Windsor in Canada and subsequently to Detroit to visit family. They've been traveling for about a week total by this time. So, 2 days prior to his presentation, the patient was seen in urgent care, diagnosed with influenza, and he was given Tamiflu to take outpatient. His symptoms, however, continued to worsen, and he developed fevers, photophobia, and dizziness, which prompted his visit to the emergency department. On arrival, he was in notable distress. He was tachycardic over 110. He was afebrile, and he was noted to be hypotensive with MAPS around 70s, measured 85 over 64. And he was also requiring supplemental oxygen by nasal cannula at that time. He was started on ceftriaxone, Unison, and doxycycline, later transitioned to azithromycin, and acute cardiac and cerebral etiologies were ruled out. And patient was subsequently admitted to the MICU for concern of sepsis with increasing oxygen requirements. On review of systems, not too much outside of what was noted above. Um, of note, the patient denied any rash, heart palpitations, nausea, vomiting, diarrhea, constipation, and had no recent falls, trauma, or sick contacts that he knew of. Regarding the patient's past medical history, we had very little to go off of. For one, because of the fact that he is from Southern California, and so we didn't have access to many records. But he also just reported a generally poor history of following up with providers at home. He did self-report some anxiety, but no formal diagnoses beyond that. He has no prior surgeries and no known allergies, and family history was only positive for one daughter with type 1 diabetes. He takes no recurring home medications, and he was only taking his Tamiflu from the urgent care prior to admission. Social history: the patient reported drinking alcohol up to 5 nights a week. He denied current or prior tobacco use or marijuana use, and he lives in a single family home with his wife and daughter. We later found out that the patient has one dog and one indoor outdoor cat, which does become relevant to this case later on. Regarding the patient's lab work, he was admitted to the MICU long enough where we were able to work him up for a pretty broad list of differential diagnoses, and I did my best just to kind of sift through some of the finer points and more relevant positive lab tests. So I'll just kind of jump through those real quickly. Regarding his chemistries and cardiac tests, we noted a persistent hyponatremia as low as 126 on admission, also hyperglycemia as high as 181 with no prior history of diabetes. The patient also had an AKI throughout much of his stay, which eventually recovered. Aside from that, we noted elevated lactate, troponins, and BNP, and then some mild elevation to his liver enzyme tests throughout much of the stay as well. Regarding blood studies, we noted an initially normal white blood cell count of 5.7, but that slowly crept up over much of the course of the admission and eventually peaked at 15.4. Some thrombocytopenia as well, initially 102,000, and then that continued to drop for much of the stay and went as low as 66,000 before recovering at the time of discharge. Um, he was also anemic, as low as 7.1 for his hemoglobin level. Further studies just sort of were supportive of like a general iron deficiency anemia. And the peripheral smear that we ordered as well was pretty supportive of that, but nothing really beyond. And we also noted elevated triglycerides to 551 and then haptoglobin of 207. So at this point, we were pretty sure that we were dealing with some sort of infectious disease cause, but we really weren't sure what it was beyond that. We tested the patient for various culture studies, looked at blood, urine, CSF, and respiratory, all came back negative. And beyond that, we tested the patient for various viral etiologies as well. And we took care to consider not just diseases a bit more common to our area, but something the patient may have encountered back at home in Southern California as well. And I've listed the majority of what I could find in the medical record here, but there were even a few beyond this that I had some trouble sifting through. Here I've compiled some imaging studies that were done with the patient earlier on during the admission. Starting with 7.6, the chest x-ray that was done in the ED, you can kind of see like strandy opacities bilaterally, but overall nothing too concerning at this point. He did present with respiratory distress, which became more profound with time, as evidenced by the later chest X-rays done between 7.7 and 7.8. So in those pictures, you can kind of see like more diffuse opacities and just greater consolidations, suggestive of maybe a pulmonary edema versus like a multifocal pneumonia, which in correlation with the patient's other clinical symptoms, that was concerning for a sepsis pneumonia picture. Then compared with the chest CT that was done in the ED on 7.6, this was done to rule out pulmonary embolism, which that was negative, but the report did note lower lobe consolidations and possible scattered ground glass opacities with septal thickening, and then a reactive lymph node enlargement as well. Our differential diagnosis for this patient was initially pretty broad. For the sake of the presentation, I used the Vindicate model to just kind of cover all my bases and do my best to hit the various systems that we thought may have been involved. So from a vascular standpoint, there was some initial concern for TTP in the setting of the patient's thrombocytopenia. However, he did notably lack a rash, but we also were concerned for HLH at the time of admission. A few of his lab studies were suggestive of a potential HLH. However, we later ruled this out in favor of the infectious etiology. Um, Regarding the infections, I did mention, a large breadth of tests that we threw at the patient, all of which came back negative during his stay. We did eventually land on one, which I'll get to, I think, at the next slide. But beyond that, we were looking for potential causes of what we thought may have been HLH. So we looked for neoplastic, paraneoplastic syndromes, potential autoimmune causes or endocrine causes, but all of that ended up coming back negative. So our final diagnosis for this patient ended up being sepsis pneumonia secondary to murine typhus, which is extremely rare nowadays. And we only came up with this diagnosis because after a couple of days of admission, we'd found the patient's wife had spoken with a friend back at home in California, and they discovered that a neighbor had recently been admitted there with similar symptoms. And that patient's workup came back positive for the murine typhus, and the patient was successfully treated with a 7-day course of doxycycline. So back to our patient, we realized that this was not something we'd considered on our differential. One of the more common symptoms with a rickettsial infection is the petechial rash, which this patient never exhibited. Um, so off the bat, we sent these serologies and we started the patient on empiric treatment with doxycycline in lieu of the azithromycin that he'd previously been on. And we noted a rapid improvement once we restarted the doxycycline. So his breathing and overall wellness just rapidly improved within even a day or two, and he was soon after transferred to the floor, now requiring minimal oxygen support, and he was later discharged. So, in light of the rarity of this case, I did want to take a minute just to further discuss typhus a little bit. So, typhus is a collective term for a group of diseases caused by the Rickettsia species, which are a little bit more well known. It relies on vector-borne transmission, often originating from a rodent reservoir. So, sources of transmission commonly include ticks, fleas, mites, just smaller organisms that people or different organisms may come into contact with. And then there are different variations of typhus based on kind of the vector that's involved in the transmission. So in our case, the most likely culprit was murine typhus or flea-borne typhus. So I relate this back to the fact that we later found out the patient has a cat that both lives indoors and outdoors. And so our best guess was that the cat ended up tracking something in that may have been flea-borne. Um, Overall, like I said, this disease is very rare now. There are some case reports where it's still seen most commonly in the southwestern US, like warmer climates, in areas where there's a greater breadth of rodent reservoir for the transmission of the disease. Characteristic symptoms include the petechial rash, which I think is a bit more well known with a rickettsial infection. Other symptoms include frontal headache, malaise, fevers, jaundice, renal injury, clotting abnormalities, most, if not all of which we did see in our patient. Uh, and then atypical findings that we noted for our patient, again, included the absence of rash and the severe pulmonary infiltration, which is not something that's commonly seen with this infection after having done a deeper dive on the literature with this type of infection. So the treatment, again, is first line is doxycycline. Second line is azithromycin, which we had the patient on for a few days, but after switching him back to the doxy, we noted a much more marked improvement. And thank you very much for your time.